Morgan's here. Good morning, everybody out there. This is Morgan Denny. This is the PT on Ice Daily Show for the Institute of Clinical Excellence. I am the lead faculty for the Primary Care PT course, as well as teaching the PT management of the post-COVID patient course. So today we are going to talk about a long COVID patient that I recently started seeing. If you haven't heard me talk about COVID before, number one, where have you been? But number two, it is still a real thing that's affecting a lot of people. Now, just to bring you up to speed in terms of COVID, the numbers and what's actually going on in the world, we have about 50 million documented COVID cases in the US currently. And that's the whole timeline of the beginning of COVID till now. So that's a lot, 50 million. If you do the numbers, that means about 1 in 6 Americans have had COVID, which is pretty nuts, right? And we've had about 800,000 deaths at this point. Now, if you break down the math, the current research also tells us that somewhere around 10 to 15% of people who have COVID at varying levels, anything from asymptomatic to highly symptomatic and hospitalized, will develop what's called long COVID. Now, if you think about the 10%, just for perspective, that's about 5 million people or more in the US who will probably develop long COVID at some point. Keep in mind, this is also only the documented cases, so anyone who had a false negative test or who never got tested but was symptomatic will also potentially develop this too. So I know a lot of people are like, well, long COVID, I'm never going to see this. Like, this is affecting a small amount of people, but we're not really like seeing it. I'm not seeing these patients in the clinic. I get that. But just for perspective, I want to kind of compare some of the numbers briefly between other things, other pathologies and diseases we learn about in PT school that we have to be aware of. So keeping in mind, again, that theoretical number of people who have or may develop long COVID in the US is probably somewhere around 5 million plus. Things like ankylosing spondylitis that we learn about in school affect about 300,000 Americans, so quite a bit fewer. Rheumatoid arthritis, I treat a lot of those people, affect about 1.3 million Americans. So again, somewhere a little bit like greater than a fifth of the number of people that will have long COVID. Something like Ehlers-Danlos is estimated to affect about 65,000 people in the US, which I would argue is probably higher because there's a lot of undiagnosed, but still 65,000 versus 5 million. So I want to start kind of highlighting some of these long COVID stories because I think it's really important in our community, in our profession, really to start talking about what is and isn't working with long COVID patients, because we can't wait 5 years till the research comes out that says like this is helpful versus this isn't helpful. Besides, half the time the research comes out and it says nothing is effective anyway. So we can't wait for that. So I want to start sharing some of the stories of the people that I'm seeing and kind of what isn't working. That way as a community, we can start looking at like, okay, well, this person tried X and it worked. I'm going to try X because my patient sounds similar. So I want to talk today about a patient that I started seeing maybe like 2.5 weeks ago. Also, if you need kind of a reminder on what long COVID is or entails, I did a previous PT on Ice on that, so just go back and check that out for a quick refresh. So with this patient, right, I evaluated her maybe 2.5 weeks ago. And I want to point out that she got COVID at the very beginning of when we recognized COVID in the States. So like March 2020. The first, I think she said about a year, even though she herself is a medical professional, she was basically gaslighted and told that it was just anxiety and it was all in her head and there was nothing actually wrong with her. And I want to point that out because that is a very, very common situation for a lot of long COVID patients, especially those that had COVID in the early days when we had no idea what was going on. So keep in mind that that is a big part of how people feel about their symptoms and also about the medical system that you will come up against. So another piece of this, and I just want to start with this piece, is that this patient is getting better. So even though she's been dealing with her symptoms for like 1.5 years at this point, she also is doing better. She's improving with all her symptoms. Her functionality is improving. She's also a medical professional. And that, I think, affords her a lot better access to care, as well as like medical literacy around understanding what may or may not help her or affect her symptoms. So these are some things that are really positive for this patient that have been helpful. She is a female. Well, she's female. She uses she, her pronouns. She's 35 years old. So she doesn't necessarily fit the older patient trajectory of developing long COVID, but she is female, and there is a higher prevalence of females developing long COVID after a COVID infection. So there's that. After having COVID, she had a lot of symptoms. So she had the classic, like, felt terrible, cough, cold, difficulty breathing, was at home and really sick for about a month or greater. I'm not going to explain the whole trajectory of her symptoms and history, because that would take an entire podcast in and of itself. But what I want to do is kind of tell you about her current symptoms, like why she's coming to PT to see what can be done. And we're just going to talk about 3 of them. So her biggest reported symptom is kind of an anterior chest pain or tightness that she can't get away from. It seems that it's always there. A lot of things can change it or make it worse. So talking, for example, if she, like during our evaluation, a lot of times she would stop and kind of have to posture forward and say like she was having an increase in her symptoms. She said sometimes like feeling nervous about something could make her chest symptoms come on, and sometimes she felt like she would wake in the middle of the night and have some of those chest tightness symptoms. Now, when asked about whether or not activity or exercise made her symptoms worse, which is a natural progression of figuring out what's going on, she actually hasn't felt comfortable doing any kind of pushing in the last couple of years, literally because she is worried about flaring up her symptoms, which is understandable because a lot of people with long COVID exercise and activity, and when we say activity, this could even mean like doing the dishes, could flare up their symptoms. So she has avoided things entirely, even though she is a previously very healthy 35-year-old. And I really mean this, like when I say avoided, I asked her stuff like, what about like walking up a hill? And she says she's literally hasn't done that. She has avoided most movement and anything that could increase her heart rate over the last year and a half because she doesn't want a setback. She doesn't want to go back to the dysfunctional kind of way she was living for a while. So that's her first symptom, is kind of the chest symptoms. And those are located kind of the top of the sternum down to the bottom of her xiphoid, and then can expand laterally kind of out to her shoulders. And she's had, in terms of her year and a half of treatment and doing stuff, she's had some body work, which she's felt was really helpful, but none of it was lasting. So that's a really good sign to me as a manual therapist, because at least I get to know this patient has had some form of hands-on therapy and it hasn't triggered anything, like it hasn't set her back. Because even though we think of manual therapy as a generally passive type of strategy, for a lot of people, it's too much input to their nervous system. So for this patient, I was really happy to hear that some forms of manual therapy thus far have actually been really helpful. So her second symptom that she was really hoping PT can help with is really bad head pressure. Now, she doesn't describe it as a headache. I'm going to say it probably has some headache form, but what she describes is that it can start in the back of her head sometimes it just is everywhere, and it feels like her entire head and face are swollen. So not exactly your traditional like pressure headache or pain behind the eye that can be very cervicogenic, but whole head, and it can change locations. It's not unilateral. This also has some triggers, but isn't consistent. So for this symptom, it can be triggered by being in the sunlight or bright light too long, which is also very much like post-concussive type of stuff, which is similar to a lot of long COVID patients. It also can be just something she wakes up with and can come and go during the day. And I will say that even though she didn't report this during our initial eval, on subsequent visits, because I've seen her for a couple weeks now, she also reported that sometimes this head pressure can feel like her head is unstable, or as if she's unsure if she's going to pass out with the pressure in her head. That's important to know, right? So that's definitely maybe like, okay, good additional information. Now the third, and just to point out, she also has no prior history of head injury, concussion, whiplash, any of that stuff pre-COVID. The third symptom that's affecting her from a functional perspective, and this is the last one I'll bring up today, is that she is having some trouble reading. And she reports with any reading or kind of like focused exercise using her eyes, like even just watching TV, she can get a lot of left eye pain. And she reports it feels swollen and puffy and just painful in her eye. Now, she's seen an ophthalmologist. She's had a full ocular screen and everything is normally there from a tissue perspective and from an ophthalmology perspective. But she's right, like just looking at her eye, you can see swelling all the way around her eye. Her eye almost looks like a little bit sunken in and it's a little bit red. So just to put that out there. And that is mostly painful with reading, watching, focused activity. But from a vestibular perspective, not so much with driving, not so much with walking, not so much with kind of that shift where you're having to focus while the world is moving around you, really more only with still type of things. Okay, so we're gonna keep these three symptoms kind of separate for now because I know I've already been talking for 10 minutes. I just wanna talk a little bit about the chest tightness, and then what I'll do is I'll probably press pause and we'll do a part 2 in a week or two when I have more information and can update you on anything. So in terms of treatment, right? During the evaluation, I did a ton of different tests. I'm not gonna have time to tell you all the things that I checked that were negative. So what I wanna focus on are some of the things that I looked at that gave me good information in terms of where I was gonna go. So in looking at this patient and kind of watching her move and breathe, the chest tension piece, I think, is coming from a restriction everywhere else. When I asked the patient to just sit still and breathe deeply, number one, this is something that was really scary for her. Taking a deep breath felt traumatizing, like it was forcing her to revisit some of her prior feelings of tightness or working to breathe and struggling. So that was hard, and we had to work into that even day one just to do a few deep breaths. But watching her move, what happened was she breathed only apically. So she was only kind of breathing through her, a little bit through her shoulders, but really through her anterior chest. Almost zero lateral rib expansion, nothing through the posterior aspect, and no diaphragm access at all. Even lying supine and asking her to take a deep breath, there was zero diaphragm involved. That's a big piece first off. In poking around orthopedically, yeah, she actually did have some really good trigger point kind of stuff throughout pecs and through scapular region and scapular musculature and fairly limited thoracic extension and joint mobility. So in my mind, I was like, okay, fingers crossed, we've got some orthopedic stuff to work on. Historically has responded really well to soft tissue work from other practitioners. So this could be somewhere for us to go. So one of the things, so in terms of my theory, I think that she basically has been guarded and protective, right? You can imagine if you spent months barely being able to breathe, not being able to take a deep breath, feeling really traumatized by that feeling of taking a deep breath and being unable to, you might also guard and protect, kind of come into a hunched position where you feel like you're protecting and only then have access to your upper respiratory region, right? So really just not using that rib expansion or anything else, only breathing through the top part of the system, of the respiratory system. So I think part of her struggle has been that she's just really overstressing this upper aspect while not accessing anything below. So while it did trigger a little bit of anxiety, the first couple exercises that I gave her, and just a couple, literally 5 breaths each direction, were laterally breathing into her ribs, and we worked on doing it both in sitting and in side lying, where you can block one side a little bit better and get more expansion, although that felt more triggering to her because it forced more air through one side. But working on that, and then just working on supine diaphragmatic breathing. She's been working on those since day one. Our first day, she felt unable to do this for more than 4 breaths in a row because it started to trigger some anxiety and some faster breathing, shallower breathing. So we just started at 5. And I want to point out with patients who have had long COVID, when you feel that anxiety is high with them, which it will be with a lot of them, you got to work on that too. And I think keeping that in mind and keeping our own biases in check is important with this group too, because like post-concussive patients, they can be really easily flared up. So while it might seem to us like, well, we're not going to make any change if we only have her do 5 breaths or only have her do this easy exercise, we also want to be really careful that we don't send these patients into a flare-up, because if we do, we have then taken our ability to treat them or get them to change anything off the table, or we'll have to backtrack for weeks. So we have to toe in a lot more slowly. So that was literally the exercises we did day 1. Now, in terms of treatment stuff, since I've been seeing her for a couple of weeks now, we've been able to add thoracic manipulation, responded really, really well. Some soft tissue work, so like cupping for the anterior kind of thorax and posterior for that matter. And we've also been able to add some light rows with TheraBand. And I know a lot of you just laughed because you're thinking, Morgan, those aren't a real exercise. I'm just gonna say for this patient, yes, they are. Not only is she tired after doing like 7 reps, but also, again, we wanna toe in and not trigger some of that over-response of the nervous system. So we are just seeing if we can add little bits at a time for this person who has literally avoided walking up a hill for the last 1.5 years. So we've done that kind of stuff, and so far it's going well. She would subjectively report that everything feels helpful, but there's no objective change that I can measure so far. Now, can I physically view her breathing with a better pattern, getting better rib expansion, accessing her diaphragm? Absolutely, absolutely. But from day 1, her technical chest expansion wasn't limited. It was about 7 centimeters, which is within normal limits. So that's not a measurable thing. And I think I will probably struggle if her insurance company tries to force me to justify some objective change thus far. But we're finding things that we can measure, that we can get further into. In terms of the anxiety piece, I just want to point out that yes, many of you are probably thinking, Morgan, chest tension and tightness can totally just be a sign of anxiety. And you're right, it can be. This patient is highly anxious, and it's honestly very understandable. Her life has changed dramatically in the last 1.5 years from being a active, exercising, young, healthy medical professional to being able to only do 1 or 2 telehealth appointments from her house in terms of her job and not be able to do anything else physical, social, without feeling she might get a flare-up. It's a pretty big shift. So one of the things I've also done is suggested to her that she might see a counselor or some kind of talk therapist just to kind of work through some of this stuff that is very PTSD, which she's very open to. Bigger challenge is finding one that's taking new patients right now, which here in Portland is a really big challenge and probably is all over the country. So I'm gonna cap it here at part 1 because I've already been talking for 18 minutes. But I just wanna say, like, long COVID patients are interesting. And the big thing is, I think as physical therapists, there's so much we can do. We can't wait for there to be research or like a diagram we can follow for these people because all of their symptoms are so variable. But we've got to start just thinking a little bit outside of the box. Start low, go slow, and just make sure that we're not just going with the classic PT stuff, but thinking about ways we can functionally change this person's symptoms and working in structures in ways that we may not normally do, especially if you're in the outpatient orthopedics world like I am. So don't be scared of these patients, but if you're seeing these people, number 1, take the PT management of the post-COVID patient course. It'll give you at least a framework and stuff to start with for a variety of patients. I will pick this up and continue this on my next PT on ice so that I can tell you about not only the eye symptoms, but also the head pressure and where we've gone there. And then at that point, I'll probably have a couple more weeks of treatment, so I'll have more ideas for you as well. So hope everybody out there has a great day. The song of the day is Long Time Gone by the group The Chicks. And we'll see you out there. Peace out, everybody. Bye.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.